Srinivas, shall we start?
The slideshow is not on.
Slides are visible. Yes.
Yeah, I think we can start.
Kadir, I think you can go ahead.
Okay, sir. Good morning, everyone. In continuation with the topics for antibiotics, we have covered in the previous two sessions about the basics of antibiotics and also about the MDR and XDR bugs, how to design and how to start an antibiotics based on the symptoms and based on the clinical picture of the patient and depending on the resistance pattern. And to know about the resistance pattern, Dr. Nandakishore in the previous class have discussed about the PCR-based assays and normal culture tissue-based bioassays and all. So in my class today, I'll be starting with how to select an antibiotic based on the source of infection. So as we all know that infection is the most frequent cause of deaths in the intensive care unit if not properly managed or properly controlled with timely introduction of the antibiotic therapies. So there are several guidelines which help us to guide in prescribing the most effective antibiotic based on the suspected source of infection. And as we all know, critically ill patients have various changes in their organ systems functioning, which thereby significantly alter the pharmacokinetics and the efficacy of many of the antimicrobial drugs. So keeping in this mind, we have to know which antibiotic we have to start for a particular source of infection we are suspecting in the host. So the application of pharmacokinetics and pharmacodynamic parameters may be difficult, but and also the prediction of the treatment efficacy can be difficult at times because of the physiological changes which happen in critically ill patients. The correlation between the drug concentration in plasma and tissues are unpredictable because the patients who are having infections, they may be in sepsis, they may be having circulatory changes, they will have renal changes like augmented renal clearance, which causes increase in the excretion of antibiotics, volume of distribution of drugs. All these factors play an important role between the concentration of drugs given the plasma and at the tissue level. So these difference in the tissue and plasma concentration becomes important as to know which is more having better tissue penetration, which antibiotic is having better tissue penetration for the suspected source of infection, which we are treating in a patient. So when we find a probable source of infection in a patient, then we need to know what is the severity of infection and how early we should start an antibiotic and detecting the urgency of the situation and what spectrum does these antibiotic which we are thinking will cover, whether we'll start off with combination therapy or synergism therapy or a single therapy, like we need to think of it. And we also should know whether it's a community acquired or a nosocomial infection. The pharmacokinetic profile, as I said, the patient is having variable mechanisms, variable factors which influence the distribution, absorption, distribution, and excretion of drugs. That is more important based on the host factors. And lastly, we also should know the antibiotic which we are prescribing, whether it has a penetration into that organ or not. Because few antibiotics where we can see they are more specific for abdominal infections. But if you want to treat infections of the respiratory tract system, the penetration of those organs will be less. Same in cases of meningitis, wherein the antibiotic penetration based on the CSF levels if we measure, it depends on the inflammation of the meninges and also based on the penetration of the antibiotic depending on the blood-brain barrier, intact blood-brain barrier. So the choice of broad spectrum antibiotics, we should think of organ-specific therapy rather than covering a broad coverage of microorganisms. Then the therapy becomes suboptimal, less effective, and it will become dangerous for the patient for the improvement in his clinical condition. So how we can minimize this? First, find out the source of infection, where the focus, and probably which organ is involved. And if we come to know this, if we narrow down our diagnosis or narrow down our clinical source of infection, we'll come to know which organ is involved and which antibiotic, which organisms are affected, which organisms are causing that organ to get affected, and which are the most probable antibiotics can cover these organisms. And depending on the site of infection, we can also know what will be the normal flora and which will be the normal organisms, commensals or normal organisms present at that site. Depending on that, we can decide which antibiotic to choose. How can we know which will be the most likely organism? There are many factors which contribute, personal patient factors like age. If the patient is elderly age, we can know if what infections are more common in the elderly people. Like if the patient is suffering from meningitis and is elderly, we should know that the patient most common organisms can be listeria. If patients is immunocompromised, uncontrolled sugars, immunocompromised patients, which are the probable source of likely sources of infections like UTIs and all, we also should know. Based on that, we can think these are the likely organisms. Community factors, whether the patient comes from a community or the patient background epidemiological data, which organisms are prevalent in those areas, and also the epidemiological preferences of few organisms have epidemiological preferences. Depending on that, we should start an antibiotic appropriately. And physical examination, we should not forget, depending on few patients may have rash, few patients may have some petechiae. With those, we can come to some narrowing down of probable source of infection. And along with it, to support that, we have lab and imaging studies like specific chest x-rays if the patient is having respiratory tract infections, lab values, derangement of RFTs or AFTs, or derangement of any blood parameters like thrombocytopenias, patients having tropical diseases. And also along with it, CT findings and CSF analysis can help us in narrowing down our knowing the probable source of infection and treating with an appropriate antibiotics based on the likely organisms which causes those infections. Another thing, as we discussed previously, as the host factors and community factors and all based on the lab investigations, everything, we also should know that drug factors also contribute to start which antibiotics to be preferred. So because each antibiotics has different tissue penetrations, few, as I told, central nervous system penetration will depending on the blood-brain barrier and the inflammation of the meninges. We should know about the clearance of drugs which are renally cleared. Majority of the antibiotics are renally cleared, exceptions like macrolides, amphotericin antifungals like amphotericin, caspofungin, voriconazole, and other antibiotics like clindamycin, tetracyclines have other ways of renal clearance like hepatic clearance. Bioavailability, we should think of it. How will be the absorption of these antibiotics when given, whether it's oral absorption is good, IV absorption and all, we should come to know. So most of the antibiotics have good absorption, like quinolones, cotrimoxazole, metronidazole and all. We also should know about the toxicity profile, how by which means if we give this drug will be less toxic. So nephrotoxic drugs who is already having a renal failure and we give nephrotoxic drugs, we should know that not to use those medications or modify based on the clinical condition of the patient. Dosing, drug modification is more important, drug dosing modification to prevent the toxicity. And lastly, cost also. Generic drugs are cheaper than a brand ones, but we should not think of all these things when we are treating an infection. Cost comes later, and first treating a infection becomes important in those cases. The other is pathogen factors. We also should know what are the pathogens which cause which infections. So susceptibility patterns, depending on different ICUs have different susceptibility patterns. How we come to know is based on the antibiograms and the most prevalent organisms which are present in our ICU. In that way, we can specifically design a most appropriate empirical therapy for that clinical source of infection. And also we should know about when we come to know about the antibiograms, we also should know what are the MIC values for each antibiotic. So comparison of these antibiotics, like the MIC values, will help in starting appropriate antibiotic for the patient. So, sorry. When you see a probable source of infection or a patient suffering from infection, we should know first thing is to obtain appropriate microbiological cultures before starting an empirical antibiotic therapy, and see the clinical parameters. As I said, we have lab investigations, we have radiological investigations, hemodynamic parameters, and all. And when we get the culture reports, narrow down your antibiotics based on the culture and microbiological data. And if there is an improvement within 48 hours of our empirical, when we think that the empirical therapy is almost same as the microbiological data profile of that infection, we can continue that, or we can narrow down our empirical antibiotics to a more appropriate antibiotic. If the patient is not improving even after 48 to 96 hours of the antibiotic treatment, then we should search for other sources of infections like non-infectious causes of fever. That is also one of the most important things in the ICUs. If the patient is getting better, then what we should do, we should discontinue antibiotics after a complete course of, like, depending on the source of infection or site of infection and the clinical response, with a duration of approximately 7 to 14 days. And the most physical examinations in predicting the, like, which organism is most likely prevalent in from the sites of infection, like as we see, otitis medias, upper respiratory tract infections, sinusitis, and upper respiratory tract infections. The most common organism, the gram-positive organisms like Streptococcus pneumonia. If the patient is having a lower GI tract, like infections of the sphincter, anal sphincter, fissure, or pilonidal sinus, we should know the surrounding organisms which are more common, that is a gram-negative, like Enterobacteriaceae family, E. coli. And if the patient is having skin rash and presents with fever and all, and if the patient is young, we should think of Neisseria infections, and in children, we should think of Haemophilus. And ecthymias, we should think of gram-negative organisms like Pseudomonas. So to start which antibiotic is more appropriate, and to know depending on the source of infection, I'll just discuss with a few case scenarios wherein we'll be able to know depending on what site of organism and how we have chosen those antibiotics for the patient. So in a case scenario, a 45-year-old gentleman, obese, hypertensive and diabetic, and a chronic ethanolic, presents to an ER with history of abdominal pain, vomitings, and low-grade fever with chills. So on examination, he was found to have right upper quadrant tenderness with mild icterus. So it means based on the history, it means it's a GI tract with mostly a liver involvement. So vitals are heart rate is around 126 per minute, blood pressure is 90/50, temperature is 101 degree Fahrenheit, and he is breathing at a rate of 24 per minute. So these are a few signs wherein we can say the patient is having some infection, which are we can see the inflammatory response like by tachycardia and hypertension. And also the blood report, as I said, we should see all these factors, primary host factors, community from where he is coming, and then lab. So the lab shows the PLC count is high, 14,000, and there is derangement in the LFTs. So the most probable we think is a GI tract. So we advise, as he was having upper quadrant pain, we advised a USG abdomen, and the USG abdomen showed this picture of gallbladder wall inflammation with some slush present in it, and some cholecystitis, inflammation of the wall. So which antibiotics would you choose at this stage? So as the clinical history with the signs and the symptoms, we should know the probable source of infection. Now this is like cholecystitis. So what will be the antibiotics will have a greater penetration for this cholecystitis, and all we should be able to make out. So which antibiotics do you prefer? Is it ceftriaxone with metronidazole, BLBLA combination, or a carbapenem with an aminoglycoside, or a fluoroquinolone plus amikacin? So if we know the probable source of infection and probable site of infection, then we'll be able to come to a narrow down our selection of antibiotic, which one is more appropriate in this scenario. So as we say, go ahead. Now the next step will be the patient is sick or he is not much sick, we're in shock and all. That helps us to select what type of antibiotic we should use. So this is a mostly gastrointestinal or intra-abdominal infections, like it can be cholecystitis, pancreatitis, peritonitis, appendicitis, intra-abdominal abscesses, food poisoning, or enteric fever. Most common organisms will be gram-negative, E. coli, Klebsiella, anaerobic organisms like bacteroids, host streptococci, and gram-positive like enterococci, streptococci, and staphylococcus. This was a CT finding, and the patient was planned for ERCP, but he continued to deteriorate in the next 24 hours. His hemodynamics worsened, requiring significant vasopressor support, was initiated on renal replacement therapy. CT abdomen was done, and now the patient has deteriorated from the first, like the presentation to the next 2 days, he has deteriorated. So what will be the choice of antibiotic will be depending on the clinical condition of this patient. So we divide into like a patient who was non-critically ill without risk factors and critically ill patients with multiple risk factors. So as I discussed, cholestatis common organisms will be gram-negative, E. coli, Klebsiella. So our first choice, if the patient is non-critically ill, then beta-lactam plus metronidazole or a fluoroquinolone can be used. Second choice will be beta-lactam with beta-lactam is BL-BLA combination, for a duration of 7 to 10 days. But the main thing we need to look here is we should have a source control for these things. Without being a source control and you continue hitting an antibiotics, the patient may not improve. If the patient is having ESBL producing, if we come to know that the patient is producing an ESBL organism, then and the patient is critically ill, we should think of either a BL-BLA combination with a aminoglycoside or a carbapenems. If we consider the patient have received antibiotics initially elsewhere and has underwent a procedure and now who is in shock, then we should consider BL-BLA combination with a aminoglycoside or a carbapenems. If the patient is having acalculous cholestatis, the most common, we think of gram-negative organisms, MDR, we should go ahead with BL-BLA combination and should drain with a percutaneous cholecystostomy as early as possible. So this was the first case. In second case, 35-year-old gentleman, chronic ethanolic, presents to the hospital with acute pancreatitis with the multi-organ failure. He had a long duration of stay in the ICU for almost more than 2 weeks. He has received prolonged mechanical ventilation, vasopressor support, and RRT. Initially, he showed good improvement, but later on, he continued to deteriorate clinically, requiring significant vasopressor supports. This was a CT done. CT showed, as per the grading, it is necrotic with inflamed pancreas. So how do we decide antibiotics in cases of acute pancreatitis? We have several scoring systems to know the severity of pancreatitis in acute or in cases where in the first 3 to 4 days of presentations, unless the patient is having coexisting cholangitis, we usually don't treat with any antibiotics in acute pancreatitis. If the patient presents in a later, after 1 week of illness, being treated with multiple, as in our scenario, we have seen the patient was treated, deteriorated for more than 4 days. He has received mechanical ventilation with vasopressor, with renal replacement therapy. Then there are high chances the acute pancreatitis can cause inflammation. The complication of pancreatitis can be seen in these patients. So the organisms, as I said, gram-negative, E. coli, Klebsiella. Along with it, there can be fungal infections also. So first choice of our antibiotics will be carbapenems or a 4th generation cephalosporin like cefepime, tazobactam, or plus metronidazole. In sick patients who have been treating in long for ICU by calculating a candida score, or a patient who requires a antifungal therapy, we should start off with fluconazole. Second choice will be fluoroquinolones along or colistin with fosfomycin. We should, as I discussed in my initial slides only, we should know the penetration of these antibiotic agents to treat those infections. We should consider that. And the second thing is, again, damage control. First thing is necrosectomy or debridement should be done for those patients to improve clinically. So acute pancreatitis, as discussed, it does not need treatment with antibiotics in the initial stages unless it is by sedative of cholangitis, or in the later stages in the second week of illness, if it is patient is having severe acute pancreatitis with the complications of necrotizing pancreatitis, we should consider antibiotics with a good tissue penetration. In a third scenario, a 65-year-old male with hypertension, diabetes, with chronic kidney disease stage 5 on peritoneal dialysis. So we come to know the patient is immunocompromised, already diabetic, and on peritoneal dialysis, complains with high-grade fever, chills, and abdominal pain. So with this way, something should be clicking our heads. Okay, there can be some infection of the peritonitis can be there. So there was a cloudy discharge from the peritoneal dialysis catheter site. Heart rates are on 10 and BP is 140 by 80. What will be the most probable diagnosis? So because of the catheter present and patient mounting fever spikes, immunocompromised elderly guy, we should think of definitely an infection, which could be a peritonitis. And how do you select this antibiotic in this patient? So as we thought, okay, peritonitis, if the patient is low risk, like as not in this case, the most common organisms will be E. coli, Klebsiella. First choice will be BLBLI combination along with metronidazole or BLBLI with aminoglycosides. And early source control, removal of the catheter and other supportive care for those patients is required. And in patients with high risk patients like peritonitis, elderly with immunocompromised, uncontrolled sugars and all, and the patient is in shock, then we should consider first choice to be carbapenems along with gram-positive cover, teicoplanin or vancomycin. If required, fluconazole. And second choice will be colicin polymyxin for more than, if the patient is already suffering from more than 2 weeks of illness. And also we should consider fosfomycin in these cases. Case 4, 50-year-old male, hypertensive diabetic, coronary artery disease, got admitted in ICU with polytrauma, prolonged hospital stay for more than 4 weeks, required multiple surgeries for orthopedic fractures, had infected processes, so received multiple antibiotics during the hospital stay and was stabilized and shifted to an HDU. In HDU, high dependency unit, he developed multiple episodes of loose stools, associated pain abdomen and febrile spikes. What will be the most probable diagnosis? With the presenting history, we should think in these cases, the risk factors, elderly gentlemen with immunocompromised status, receive multiple antibiotics for more than 4 weeks. So we should think, and he's presenting with fever and loose stools. So most commonly, he may be suffering from some GI infection, or it can be antibiotic induced something. So we should go ahead with first routine examination of the stool with gram stain, culture sensitivity, hanging drop for ova and cyst for looking for any parasitic infestations. The most probable, if we see based on the clinical history, can be a antibiotic previously multiple times exposed to antibiotics. He can present with a Clostridium difficile diarrhea. So we should send a toxin for Clostridium difficile, toxin A and B. In these patients, if the patient, depending on severity of disease, if it is mild to moderate, metronidazole 500 mg TID for 10 to 14 days of duration. If it is severe, then 125 mg of vancomycin, because the oral vancomycin absorption will be more. So we should prefer oral vancomycin in these cases. 125 milligram per oral QID, 10 to 14 days. If it is a recurrent infection, then we should treat with metronidazole 500 mg thrice daily. And if it is severe, along with metronidazole, we should add vancomycin also for it for a duration of 10 to 14 days. The most, this is again a similar slide. The most common organism associated with intra-abdominal infections are E. coli, gram-negative organisms, Enterobacter species, Klebsiella, Proteus species. Most common is E. coli, which is almost amounting for 32 to 60%. Gram-positive organisms like Enterococci, Streptococci, Staphylococci, anaerobic species like Clostridium and bacteroids. Empirical therapy, if the patient is not critically ill, you can start BL combination, beta-lactam along with metronidazole, or if the patient is critically ill, may require BL-BLA combination along with an anaerobic cover. If the patient is severely ill in shock, we should go ahead with carbapenems. Depending on the risk, as I said, we should go ahead with carbapenems. Next case, a 53-year-old female, hypertensive diabetic with high-grade fever, chills since 3 days, abdominal pain with nausea and vomitings, complaining of dysuria, increased urgency, and costovertebral angle, like renal angle tenderness. So we can have a clue from this one. So it is more looking like some infections of the urinary tract or a kidney, can be pyelonephritis with cystitis. The heart vitals are heart rate is 130 per minute. She is hypertensive, 80 by 46 millimeters of mercury, temperature of 102 Fahrenheit, and breathing at a rate of 24 per minute. What is the most probable diagnosis? So we got a history, clinical findings, and also the parameters like hemodynamic parameters, like she is in systemic inflammatory response like heart rate are high, hypertension, temperatures are high. So the most probable diagnosis will be some UTI, acute urinary tract infection, can be a pyelonephritis or a cystitis. So which antibiotics do you choose? So uncomplicated UTI, like cystitis with mild hydronephrosis, the organisms are again Enterobacteriaceae family. E. coli, Klebsiella can be a gram-positive Staphylococcus in sexually active young women, and also Proteus. First choice, if the patient is stable without any hemodynamic abnormalities or without any structural and anatomical problems of the urinary tract, we can start off with nitrofurantoin or quinolones, fluoroquinolones, or third generation cephalosporins. In acute uncomplicated pyelonephritis, the organism is similar to E. coli, Klebsiella, Proteus, Pseudomonas, and Enterobacteriaceae species, mostly ESBL are seen. A BLBLI combination along with an aminoglycosides have a better penetration in the urinary tract. We also can advise fluoroquinolones. If the patient is getting like sick or anything, we should start with fourth generation cephalosporin or beta-lactamase inhibitors. In less than 10% of the patient, there can be a fluoroquinolone resistance. In those cases, we should go ahead with BLBLA combination. If it is complicated pyelonephritis, mostly ESBL producing organisms, these are carbapenemase producing. So E. coli, Klebsiella, Proteus, Enterococcus, those start with the BLBLA combination or directly with carbapenemase. And we also can, if the patient is having shock, we can start with the polymyxin or amikacin. But we should also consider in this scenario, two nephrotoxic drugs we should consider before starting if we have to think either carbapenem or go ahead with polymyxins. So complete course of treatment for at least for 14 days, de-escalate as per the cultures. As I said earlier, we should not continue empirical therapy for a longer duration. We should narrow down our treatment choice based on the cultures, and definitely source control like urological interventions like DJ stenting or nephrostomy to relieve the obstructive symptoms in those patients. Asymptomatic bacteriuria, we should not treat. The organisms are similar unless the patient is a pregnant female or the patient is undergoing any urological procedures, then only we should consider treating asymptomatic bacteriuria. Other case, a 25-year-old young male referred from other hospital with a high-grade fever with chills, redness, and swelling of the left lower limb associated with pain since 1 week. He sustained a small injury to his limb during a recreational sport activity 1 month back. He was treated with empirical antibiotics covering mostly gram-positive and gram-negative, but the patient did respond. So it looks like the patient was not received appropriate empirical antibiotic. What will be the probable agent and which antibiotic would we choose? So in this patient, we should consider it as skin and soft tissue infection. We should know the penetration of which antibiotic is better in these soft tissues and the probable source of infection. So cellulitis, as there is a grading for skin and soft tissue infections like grade 1, grade 2, and 4 grades, depending on the level of involvement of the dermis, epidermis, subcutaneous tissue, muscle layers. So if it is cellulitis, the common organisms are group A, B, and C streptococci. Streptococcus pyogenes is the most common organisms. So we can treat if the patient is as an outpatient, we can treat with BLBLA combination like amoxicillin clavulanate or a third generation cephalosporin. BLBLA combination, if second choice, along with clindamycin or doxycycline, mild forms can be treated orally. If the patient develops a necrotizing infection, the most common organisms include again Streptococcus pyogenes, Staph aureus, anaerobic groups, and also Enterobacteriaceae, polymicrobial growth can also be seen. So in these patients, the patient is clinically deteriorating or is having any signs of worsening of his hemodynamics or in worsening of his symptoms, we should start with BLBLA combination intravenous dosing, along with early surgical debridement of that tissue, because if a tissue becomes dead, then the penetration of again the antibiotics becomes a question mark. If the patient is clinically sick and with worsening of hemodynamics and other parameters, we should start off with carbapenems and along with clindamycin or daptomycin or linezolid. Again, daptomycin and linezolid have better penetration of these antibiotics into the soft tissues. These were the guidelines in like published by the IDSA way back in 2014, but the similar guidelines are still continued. If the patient is having non-purulent infections, necrotizing or cellulitis or erysipelas, if it is severe, it should be going ahead with the emergency surgical debridement along with sending of cultures and starting empirical antibiotic covering most common organisms, as I discussed, like gram positive and gram negative. The patient is having severe infections, and we also should send culture and sensitivity is a must. With a moderate or mild infection, we can treat with intravenous penicillins, ceftriaxones, cephalosporins, and clindamycin. And if the soft tissue infections are purulent, like furuncle, carbuncle, or abscess, severe, we have to go ahead with IND, incision and drainage, culture and sensitivity based on that empirical antibiotics. We also should know if the patient can have resistant infections like MRSA and all. So we should cover those organisms also in these cases. In moderate to mild cases, we can start with trimethoprim, sulfamethoxazole, or doxycycline. I said most common organisms are gram-positive organisms. First choice will be tigecycline because of better tissue penetration, daptomycin at a dose of 6 mg per kg, or linezolid. Second choice, again, linezolid, minocycline. And the best thing is first source control by doing an early surgical intervention. If it is necrotizing or pyomyositis, we should know whether it's community acquired or it can, if the patient is in hospital, is it hospital acquired? We should know about the basic antibiogram, and to target those organisms should start off with similar most appropriate antibiotic like daptomycin or linezolid can be used. Clindamycin, appropriate dosing is also required. In most cases, we see inappropriate dosing can lead to these resistant infections. Clindamycin 600 mg Q6 hourly for 2 weeks, or minocycline 100 mg Q12 hourly for 2 weeks. And the next thing is bone and joint infections. We should know what will be the probable sites of infection and the probable organisms. If it's an acute osteomyelitis or a septic arthritis, most commonly will be gram positive along with gram negative organisms. So we can cover first choice will be ceftriaxone with a cloxacillin. Second choice will be BL-BLA combination along with a gram positive coverage like vancomycin. Surgical debridement, if it doesn't get better, we should go ahead with surgical debridement, and the treatment should be continued for a duration of 4 to 6 weeks. If it's a chronic osteomyelitis with the sinuses draining outside, we should suspect polymicrobial organisms. And usually the patient who are having chronic osteomyelitis and all, we should think immunocompromised patients, and then can be a mycobacterium tuberculosis also, and a fungal infection can be seen. No empirical antibiotic therapy should be given in these cases, and the patient should be planned for a definitely surgical debridement. And if post culture, if we get a proper organism, then a duration of 6 weeks of treatment is required based on the culture sensitivity report. If it is a joint infections, prosthetic joints post TKR or post THR can be a coagulase negative staphylococcus, streptococci, GND, gram negative bacillus, enterococcus, and anaerobes. So we should start off with 4th generation cephalosporin plus a gram positive, as I said, vancomycin or a teicoplanin. If the patient is sick, we should go ahead with carbapenems or plus teicoplanin and vancomycin for gram positive coverage for a period of 3 to 4 weeks, and we should consider replacement of a prosthetic infected joint. Cardiovascular infections, most commonly the infection of the native valves or the prosthetic valves. Can be multiple causes can be there in most commonly seen patients having chronic drug abusers and all. We see these cases, and also patient having indwelling catheters for a longer duration, like patients who are CKD patients requiring dialysis, having permacats and all, can have this infective endocarditis. So according to the localization, again, a left-sided infective endocarditis, native valve, prosthetic valve, early within 1 year after surgery or late after 1 year after surgery. Right side, as I said, infective endocarditis most commonly are device related. So native infective endocarditis, so we have to send cultures, 3 cultures, mostly 1 hour apart. Most common organisms are viridin streptococci, other streptococci like group B, C, and G, Streptococcus bovis, enterococci, and Staph aureus. First choice of drugs in these patients will be ceftriaxone, 2 gram IV BD, or penicillins like 20 million units IV 4th hourly. ampicillin, and to know if we come to know that there is a gram-negative cover, gram-negative organism, or a patient having indolent course, we should add a gram-negative organism also, gentamicin. Second choice of drugs will be vancomycin in 30 mg per kg, 24 hours like OD dose, or in a 2 divided doses, or a ceftriaxone with 2 gram IV twice daily. Duration of therapy should be almost 4 to 6 weeks. Infective endocarditis, like a native valve, and the patient is having severe source of infection, we should think of MSSA or MRSA along with gram-negative organisms. So before getting cultures, we should start off with vancomycin, BLBLA combination, plus or minus, as I said, aminoglycosides, gram for negative coverage. If the patient is having like worsening of the conditions, we can think of carbapenems, and duration of therapy should be continued for up to 4 to 6 weeks. Prosthetic valve endocarditis within 60 days of the replacement, then staph epidermidis or staph aureus, we should treat with third generation cephalosporins plus vancomycin. If the patient is sick, we should start off with BLBLA combination plus vancomycin. In conditions where the patient is not getting improvement or not, we should also consider removing this prosthetic valve. If it is more late prosthetic valve endocarditis, if it's more than 60 days, the treatment will, the organisms which are most commonly associated with this infection are like native endocarditis, as I told earlier. We have to treat it again of fourth generation cephalosporin plus aminoglycoside, or vancomycin plus aminoglycosides. And if we see in a tea, if the vegetations have a like fungal etiology, so of fungal etiology, we should also consider adding an antifungal therapy. Cultures of removed valve may be negative, but valve gram stain can be positive. There is also one entity called as culture negative endocarditis, wherein pathogens most commonly are Abiotrifa, Enterococci, and PCN resistant organisms. So we should start, first choice will be ampicillin sulbactam plus gentamicin for a duration of 6 weeks. Gentamicin should be given for 2 weeks. Also, we should consider quinolones OD for 4 to 6 weeks. If there has a group of organisms, then ceftriaxone along with or a fourth generation cephalosporin should be given for a duration of 4 to 6 weeks. The second choice, depending on the condition of the patient, we should consider ampicillin 2 gram 4th hourly for 4 weeks plus gentamicin, or a monotherapy with ampicillin sulbactam 3 gram 6th hourly for 4 to 6 weeks. If duration up to 4 weeks, if cultures are usually negative, so PCR remains a powerful tool in these cases, because the main thing is, as we are discussing, it's a culture negative. So we have to treat for a duration of 4 to 6 weeks. CNS infections, which we commonly deal, are bacterial meningitis, meningoencephalitis, brain abscesses, and subdural empyema. As I told, CNS infections are difficult to treat based on the penetration of these antibiotics into the CSF fluid, depending on the meningeal inflammation along with the blood-brain barrier. So drugs which are having more better penetration and penetration along when there is an inflammation of the meninges, that has to be considered. So the cephalosporins have a variable penetration of these antibiotics, as when we check the therapeutic drug monitoring through either a EVD or a lumbar puncture drain, we see a variable concentration of these drugs into the CSF. The penetration is like different. So for treating a CNS infections, the dose of antibiotics will be slightly higher than treating a respiratory tract infections. In a community acquired meningitis, the most common organisms are gram positive, Streptococcus pneumonia, Neisseria meningitis, and H. influenza. We cover, as I told, we have to give a little higher dose. We cover with ceftriaxone 2 gram IV 12th hourly. The second choice will be chloramphenicol. We should add steroid for the first 48 to 72 hours. As I told, if the meningeal inflammation is there, the penetration of antibiotics will become easier. If the meningeal inflammation comes down and all, the penetration of antibiotic depends on the blood-brain barrier. Elderly patient, as I told, in deciding antibiotics, the patients are elderly. We should also consider in CNS infections Listeria and other aerobic gram-negative bacilli. In those patients, we should cover with ceftriaxone or plus vancomycin or an ampicillin 2 gram IV 4th hourly. The second choice, if the patient are having secondary or a prolonged course, we should add a BLBLA combination along with vancomycin or trimethoprim sulfamethoxazole 5 mg per kg Q6 hourly. And in severe cases, we also should consider starting in a carbapenem group of antibiotics. Vasophysical fractures, we should consider anaerobic organisms also, streptococci, bacteroids, because they are in direct communication with our oral cavity. Basal skull fractures needs anaerobic cover. along with third generation cephalosporin plus vancomycin. In immunocompromised patients, the organisms remain similar, like Streptococcus pneumonia, Neisseria meningitis, Listeria, Pseudomonas aeruginosa. First choice will be vancomycin plus ampicillin or plus cefepime or ceftazidime. In second choice patients who are not requiring, who are clinically deteriorating, we should consider carbapenem along with vancomycin plus ampicillin. Post neurosurgery patients or penetrating head trauma injury patients, we should consider the organisms are gram positive and gram negative, and Acinetobacter we should not forget. So vancomycin plus cefepime or vancomycin plus ceftazidime. The duration of antibiotic course will be almost 14 days. And in severe cases, if the patient is not responding, we may even need to consider giving intraventricular therapy in severe cases. Patients who are having ventriculitis or having VP shunt, there are high chances that they may have ventriculitis. So the penetration of the antibiotics will become difficult in those cases. So in these patients, we should consider giving antibiotics intrathecally. Next is respiratory tract infections. Most common organisms, we should again differentiate whether it's a community acquired or a hospital acquired infections, common organisms. And what will be our first choice of antibiotics? As I said, beta-lactam or beta-lactamase inhibitors and or third generation cephalosporins. Fluoroquinolones and macrolides, this second choice, or like these concentration of these drugs, fluoroquinolones and macrolides, are higher if you consider tissue plasma versus tissue penetration. The level of these drugs reach a higher concentration in alveolar cells and epithelial lining fluid. So we consider fluoroquinolones and macrolides for community acquired infections. We can also consider beta-lactam antibiotics or third generation cephalosporins. If you are severe cases, you have to give IV antibiotics, ceftriaxone or cefeprazone sulbactam. The second choice will be again piperacillin tazobactam along with azithromycin. If we consider viral infection, viral associated pneumonia, we should consider neuraminidase inhibitors like oseltamivir. Aspiration pneumonia, mostly the common organisms be from oral flora, so we all should also consider anaerobic cover for them. Beta-lactamase inhibitors, beta-lactamase inhibitors along with anaerobic cover like clindamycin can also be considered in these cases. Lung abscess or empyemas, again organisms will be Streptococcus pneumonia, E. coli, Klebsiella, Pseudomonas. So BL-BLA combination along with the clindamycin. If we are suspecting there is can be an MRSA, so duration of therapy should be increased, and antibiotics like linezolid can be considered in these cases. In patients developing pneumonia who are already immunocompromised, we should also cover them with PCP prophylaxis, and along with fungal infections also should be considered. So BL-BLA combination plus azithromycin plus cotrimoxazole for PCP coverage plus antifungal. And if the CD4 count, if the patient is retropositive, then we should also look for the CD4 count, and if it's less than 100, we should consider Mycobacterium tuberculosis and can start an empirically anti-tubercular drugs in these patients. Febrile neutropenia. In these patients, what is febrile neutropenia? Is a single patients who are having a fever spikes of 101 on one occasion or 100.4 on at least 2 occasions 1 hour apart. Neutropenia, if absolute neutrophil count is less than 500 and expected to fall below 500 in the next 48 hours, is called as febrile neutropenia. So febrile neutropenia patients, they are mostly immunocompromised, gram-negative organisms along with antifungal. If the patients are hemodynamically stable, then we should consider anti-pseudomonal cephalosporins, BL-BLA combination with fourth generation cephalosporins. If the patients are critically ill, we start with piperacillin tazobactam plus aminoglycoside plus vancomycin or teicoplanin, and also plus or minus antifungal depending on the patient clinical condition. Combination therapy should be considered. PCR-based assays should be sent, and de-escalation of the therapy based on the cultures is most important. Infections in pregnancy. Most commonly, as I said, asymptomatic bacteriuria should be treated in pregnancy. Common organisms are again gram-negative bacilli, E. coli, Klebsiella, chlamydia, and gonococci can be used. Oral beta-lactamase inhibitors like amoxiclav, augmentin, and clavulanic acid or cephalosporin can be used. And these organisms can cause pyelonephritis in more than 25% of the patients. They can cause preterm labor and low birth weight BV. So this should be treated in patients who are having asymptomatic bacteriuria. Peripheral infections, again, most commonly a gram-negative, a gram-positive, and a gram-negative organisms can be seen because of the normal flora which is there surrounding the genitourinary tract. If there is no features of sepsis, then we can start off with oral or IV forms of beta-lactam. Beta-lactam is inhibitor like augmentin, amoxiclav, ceftriaxone, along with anaerobic cover, metronidazole. If the features of sepsis are there, then we should start higher antibiotics like BLBLA combination IV and along with a gram-positive cover like vancomycin. So choosing an antibiotic, first, as I said, we should probably confirm the diagnosis, what exactly we are treating, know the focus or the location of the site of infection, and based on that, what are the most probable organisms which can be seen infecting that site should be known. And other host factors we should think, whether the patient's risk factors, immunocompromised, hypertensive, diabetic, elderly, community risk factors coming from, is it a community acquired infections or is it a hospital acquired infections? We should know. We should physical examination, and to support that, we should have a laboratory and imaging investigations. Choose the best antimicrobial therapy, most likely active and specific organism. We should also know penetration of that antibiotic for that infection. If the penetration of antibiotic is not appropriate, and again, then that will become detrimental to the patient and the clinical condition might not improve. Preferably consider bactericidal drugs, and in other cases, special considerations where we can optimize based on the response of the patient. How long we should continue empirical therapy and what will be the hazards of empirical therapy? As I said, to prevent the drug resistance and inappropriate use and for longer duration, cost burden can worsen the clinical outcome of the patient. So discontinuation of the empirical therapy when the cultures are available, narrow down your antibiotic selection based on the culture reports. And we also should consider the withdrawal of certain antibiotic classes producing drug resistance because of their PKD properties, not giving those antibiotics for a longer duration. And the third thing is, how can we prevent again resistance of infections by increasing the dose, increasing the duration of empirical therapy by doing antibiotic cycling. Like based on the antibiogram, we should change our preferences of antibiotics for treating those infections to avoid antibiotic resistance in our ICUs. Thank you.
Thank you, Khalid. Ghanshyam? Ghanshyam? Khalid?
Sir. Main thing I was stressing on is the tissue and plasma concentration of antibiotics and the level of drugs which are there. So we should also consider which are concentration dependent, which are time dependent antibiotics. We should know that. And the antibiotic antibiogram of the local ICUs is more important before starting an empirical antibiotic in patients when we are treating in ICU patients. And depending on the severity of illness, which antibiotics to be changed and how we should optimize our choice of antibiotics in this patient should be considered. And duration of therapy, if we get a culture report early, if we are using a PCR-based assays, if we get a culture report early in the course of treatment, we should narrow down our broad spectrum antimicrobial therapy to narrow down to a limited and hitting a bullseye, which organism we got isolated from that report and treating them as per that reports. And also we should consider clinical condition of the patient rather than just going by the reports. One more thing, rather than treating that report, we should see how the patient is improving, not just by the report we change the antibiotic and suddenly go and with start off with higher end antibiotics, which can again cause a problem of resistance in our ICUs.
Yeah, Pradeep, if you want to add something.
Sir, actually, Kadir has given a detailed description of what antibiotics to choose, first choice, second choice in each and every infection. Most of the things are covered, sir. Only thing is, the route we all in the ICU we all get it right in the sense that we all give IV antibiotics only. but dose and frequency should be adjusted daily. Apart from that, the host factors are to be taken into consideration, whether the patient is immunocompromised or immunocompetent. And secondly, whether he is sick, very critically ill or not. Based on that, you will know, you will understand whether your bugs, they are either resistant to which flora they belong to, their hospital acquired flora or community acquired flora. And based on that, your resistance patterns are known. You should also consider intrinsic resistance. So like in the last class, Nandakishore has clearly told some bugs are intrinsically resistant to certain antibiotics. You should consider them. Apart from that, you should also emphasize on the thing that the penetration of the tissues should also be considered. Based on these factors, you should select your antibiotics. And apart from that, you should also consider the pharmacodynamic and pharmacokinetic properties, especially augmented renal clearance. Err on the side of higher doses rather than on the lower doses. And sidality, bactericidal and bacteriostatic, they are in vitro, not in vivo. So depending upon that, you have to choose your antibiotics. And in the case of renal failure, especially, these drugs are adjusted as per CKD, that is chronic renal failure. Acute, what we come across is acute renal failure, or where the function of the kidney is not completely lost. So erring on the side of a little bit on the higher dose will help us.
Kansham?
Yeah, I think most of the points have been covered, Srinivas. Only a couple of things. See, in an Indian setting, we always need to keep in mind the probability of tropical infections, and many a times a simple cephalosporin with tetracycline would cover majority of the tropical infections. That is one thing that we need to keep in mind. Second thing is the incidence of viral infections is also very high, especially now post rainy season. You might get a lot of dengue cases. Again, no amount of antibiotics are going to work in such situations. So try to kind of have some sort of an understanding of whether you're actually dealing with a bacterial infection, and if it's a bacterial infection, is it community acquired or hospital acquired? Whether it is a simple tropical infection where your simple antibiotics can work instead of straight away jumping to the big guns. So there are a couple of things that I just wanted to highlight.
Yeah. So yeah, I think it's been an exhaustive review, and as usual, very informative and learning points. A few just take-home points I would like to say. Prescribing antibiotics is not a right. Prescribing antibiotics is a privilege and a responsibility. That's how we can improve the resistance patterns which we are seeing and we are facing every day. There are a few Ds of antibiotic therapy which all of us should remember. Like the NABH, when they ask for drug safety, they ask for right drug, right dose, right patient. Same thing applies to antibiotics as well. The right drug in the right dose for the right duration, with the right dose modification, with right de-escalation. Along with this, there is something called as defined daily dose, which should be adhered to avoid overuse of antibiotics. All this will result in antibiotic discipline. So these 6 days will be the pillars. They are the cornerstones of an ethical, scientific, and effective antimicrobial therapy. All of us should be able to do this very easily. It's not a big challenge. It is the only thing we need to understand and we need to follow is that the bigger, it is not always true that the most expensive antibiotic is the most effective antibiotic. And it's also true that the most recent antibiotic is not the most effective antibiotic. So, and the same thing applies to antifungals as well. So we will need to understand what is their mechanism of action, how to use them and how not to use them, and what are the new drugs. And that's what we will discuss next week with Dr. Mithilesh, and he will be guided by me. Mithilesh doesn't need any guidance, but it's on paper, I am guiding him. But don't miss this one on antifungals because everybody everywhere you go, you have this query on when to start antifungals, what to start, how to tailor, what is the role of combination, what is the effect of PKPD on antifungals. So please do join us next week on this platform. Thank you very much. Have a good day. Bye-bye.
Thank you, sir.
Thank you, sir.